that's complicated.
Yes, about what meaning that has in the industry. I sent it to DFR. I think that issue may have been discussed as part of the working group.
Yeah.
Over the summer, and heard from some of the players in PBM space that will have a significant.
I've heard, yeah, we've heard
impact.
from the payers that it has, requires more testimony, and so. And it's coming in a really late time, so my suggestion is that we leave that for another day. I'm sure the implications of it at this point, except that I know that some increase. Okay, so let's look at what you've got for us, and then we will look at the bill.
I believe we were doing 233 now.
Yeah.
Yes.
What addition is
It's just the as passed by the House, except for that,
with that addition? So with an amendment.
except for that, right, so yesterday we looked at the one potential instance of amendment that you have at this point. You can look at again if you want, but that was about the scope of the information that the Office of the Healthcare Advocate would have access to. Oops, it's 7.
So this is our proposal amendment to the bill.
Well, right now, I've just pulled up the actual bill, if you want to look at the proposal of amendment.
Well, let's look at the proposal first, and then we'll scoot through the bill and decide how to go from there.
That is. Oh, so this is the single instance of amendment. We would change in section 1 in the new chapter in section 3613, we would strike out subdivision B3 and put in a new one. This is the markup version of it. It would look clean. If you were to put it forward. But instead of giving the Office of the Healthcare Advocate the right to receive or review copies of all materials provided to or reviewed by the Commissioner, under this chapter, it would instead give them the right to receive and review in full, including any exhibits, attachments, appendices, or other supplementary materials, certain materials. The preliminary report of any examination conducted by or on behalf of the Commissioner under this section, the PBM's submissions or rebuttals to the report, if any final examination report adopted by the Commissioner, and the Commissioner's order adopting the final examination report. And it keeps the language about the not further disclosing any confidential or proprietary information, and it not being subject to subpoena or discoverable or visible in evidence.
And this doesn't have any requirements that confidential information be revealed. Theoretically. Just.
In fact, it's the opposite.
It specifies that they sure.
So this narrows.
It does
Narrows the scope of what they would have
Okay.
access to
Access.
from everything that the Commissioner gets to more narrowly focus on the results of an examination by the Commissioner and the reports and responses.
Okay. Questions there? Good. Let's go to the full bill for a final review. This would be amended to the bill.
Right, because it was just one provision. I did not give a strike all.
And so we need the bill. Jen, you can put it up.
Is it just as passed by the House?
Yep, since by the House.
As passed by the House
With
and
that
then
potential.
with our proposal amendment.
All right, so as we had looked at, when we walked through this before, this is H 233, an act relating to licensure and regulation of pharmacy benefit managers. It creates a new comprehensive chapter on pharmacy benefit managers that pulls in a lot of pieces from a few different places in the existing law, as well as a number of new provisions. It comes up with a licensure and regulation framework for the Department of Financial Regulation to license and regulate pharmacy benefit managers. Talks about what the purpose is. It has a couple of pages of definitions. Let me know if you want more detail on anything, otherwise I'm just going to sort of run through it in here. directs DFR to adopt rules. Has a reporting or annual reporting requirement from DFR to report to this committee on and others on PBM's compliance with this chapter. It has a licensure requirement that anyone establishing or operating as a pharmacy benefit manager must get a license from the Commissioner of Financial Regulation. It sets licensure fees, an initial application fee of $1,600 and an initial licensure fee of $10,000, followed by an annual license renewal fee of $12,000. These may be, this will go to the Finance Committee and they may look at those fees at that point.
Yeah.
Then we had prohibited practices, so almost all of these prohibited practices are the same as what's in existing law. These are things that PBMs cannot include in their contracts. One that is about disclosure of information, or having a pharmacist or pharmacy disclose information. It also has the copay accumulator language in it requiring the PBM to attribute any amount paid by or on behalf of a covered person, including discounts and coupons, toward out-of-pocket limits under state law, the deductible, if any, and the annual out-of-pocket maximums to the extent permitted under federal law. And then it specifies that copay accumulator provision does not apply in certain circumstances, like when there's no generic option available, or there is a generic option, but it doesn't work for the person. They've gotten authority from the payer. Also, we have our fairly standard carve-out language around high deductible plans. I'm not trying to do anything to mess up eligibility for a health savings account. We have the ban on spread pricing. That will take effect over time as existing contracts expire. There's an enforcement that has DFR enforcing the provisions of the chapter, allowing the commissioner to examine or audit the books. Here in this subdivision B3 is where the Office of the Healthcare Advocate revised language would live with the amendment that we just reviewed. There is also the ability for a pharmacy, pharmacist, or anyone else injured by a PBM's violation of the chapter to bring a private right. It gives them a private right of action in court. But a disclaimer that we're not trying to conflict with federal law. Allows DFR to use its billback authority to bill the PBMs for the costs of regulating them. Then we have the PBM relations with health insurers. Again, this is largely from existing law. We have PBM required practices with respect to health insurers. So this one was insurer audits. So it was required practices. Then we have PBM relations with pharmacies and required practices there. Again, most of these are coming from from existing law and being transferred over into this new chapter and repealed from the existing law. Then we get to section 2. So we've left the new chapter. We're into existing law here and insurance and advertising practices. And this is adding PBMs to existing prohibitions on health insurers using deceptive or misleading practices or materials to advertise their products. Section 3, some retail pharmacies and filling of prescriptions. We have a new definition of direct solicitation. It comes up later in this language, but there are a few things as well. Has again the health insurer PBM not excluding any amounts paid on or on behalf of a covered individual, including discounts and coupons when calculating their out-of-pocket and deductible. So basically the same language in a slightly different context as what was on the PBM chapter with the same exceptions. Also requires insurers and PBMs to kind of leave the regulation of prescription drugs and pharmacies and pharmacists to state, federal, and federal law and the Vermont Board of Pharmacy. And then it gets into the direct solicitation stuff about PBMs and pharmacies not making a direct solicitation to the beneficiary of a plan offered by an insurer unless certain, something has occurred, like the beneficiary has given written permission, or the supplier has furnished a prescription item to the beneficiary and is getting in touch to coordinate delivery, or it's has to do with a pre-existing relationship. And then subsection E says the insurer and or PBM cannot alter a patient's prescription drug order or their choice of pharmacy without their consent. And then it specifies this does not interfere with the generic substitution law. Still have the duty for the pharmacist to substitute the lowest cost drug, but that has to come from the pharmacist following the generic substitution law, not the insurer or PBM changing what was prescribed. Then we have some repeals, so repealing existing provisions on PBMs, regulating PBMs and their activities on July 1st, 2029, and then clarifying kind of how these interact between now and then. So to the extent that any provision of the existing PBM laws conflict with any provisions in this chapter, then the new provisions from this act would control. And we have some applicability, so certain provisions in the new chapter relating to contracting and benefit design will apply to plans issued, offers renewed or re-credentialed on or after January 1st, 2025, but in no event later than July 1st, 2029. So giving a transition period as existing contracts expire, and then at least annually through 2029, any PBM that is still using spread pricing under an existing contract must disclose to the insurer, DFR, the Green Mountain Care Board, and the Office of the Healthcare Advocate what the spread was. So we're phasing it out, but for contracts that are already in existence and using those, this would have reporting occur. And it would give a person doing business in the state as a PBM on or before January 1st, 2025, a year to come into compliance with the licensure provisions, recognizing that process may take some time. Section 6 creates 3 positions at DFR to do the PBM regulation. So an attorney, an investigator, and and 2 investigator positions, and an attorney and 2 investigators. It appropriates $405,000 to DFR from the Insurance Regulatory and Supervision Fund, which is where all of the licensing fees and other fees go in to a DFR special fund in FY25 to support the department's work and really to support those positions. And take effect on July 1st.
Good. That's it. Questions for Jen? So this bill will go to finance, obviously, the fees in there.
Yes, this will go to finance and appropriations.
Yeah.
Still in progress.
Okay, until we have our amendment.
Yep.
We should probably vote on the amendment first and then consider the bill.
And I will clean it up. And just take out the,
Oh, the yellow,
oh yeah,
got the yellow. Oh, that's our favorite color today. Our happiness card was to stare at our favorite color.
oh,
There.
or there are options for what that favorite
So
color
you can look over at the pink coat.
Or the peach.
Oh,
jacket.
peach, that one, is winning. That's winning. Yeah, peach coat that's got this place.
Or the blushing face.
Okay, committee, I'd entertain a vote at this point, and discussion. First would be on the proposed amendment for the healthcare advocate information piece.
1.1.
Why don't you make it 1.2, because I'll take the highlighting out of it.
Point 2,
I'll make a motion to vote favorably on 1.2 amendment to SH 233.
A second,
So amendments, so
just the amendment, right? Is there a second for the amendment?
Sure.
Sure.
Yeah.
Oh my God. I don't actually think so. All right.
We don't really need a second, you know, you don't really need
We're
a
not
second,
Robert's
but we do
rules.
it.
I know.
Yeah.
Okay,
Okay, discussion.
discussion.
Oh, it's up to you, clerk. Go, it's all yours.
All right, we are ready for vote. Senator Gulick, yes. Senator Hardy. Yes. Senator Williams.
Yes.
Vice Chair Weeks.
yes,
And Chair Lyons.
Yes.
500 on the amendment.
Which I will now send to Kiki because I just took all that highlighting.
Hold on, so wait, see who's reporting this. And then on the bill,
Do we have a, you're putting on the same sheet with the bill?
I was doing two.
Oh, exactly. Well, you're the clerk.
H 233 as passed by the House with proposal of amendment.
Is that a motion?
You get good at this, guys, just saying.
Yeah.
That is a motion. I make a motion to vote
Okay,
favorably.
is there a second on the motion for 233?
Yes, I would love to second it.
Thank you, Senator. Okay, discussion.
Okay, Senator Gulick, yes. Senator Hardy,
Yes.
Senator Williams.
no,
Vice Chair Weeks. And Chair Lyons.
Yes.
3-2-0. And who will report this bill?
I'm open to that. Someone would like to report the bill. But I'm putting my peg on 766, so if someone would like to report 233, I'm happy to share the responsibility.
Can I bring a whiteboard in?
Are you volunteering to report the bill?
Sure.
Okay. It's good. Well, it'll be a lot of help for you.
Thanks.
I think it's a good bill. I think there are concerns that I think the payers are going to have, particular on spread pricing, but we've taken testimony on it. And we'll get a section by section. All right. Thank you, Senator Brewer. Okay. And so I've asked Katie to finish up on, we're gonna go to 766 and go through it. And with an intent of trying to finish it as much as possible today. Possible, though I did put it on the agenda, but it's not, may not have on the written agenda. And I asked Katie to finalize 879 so we could consider it for a vote today, because if you do it today, it'll make its way into appropriations in a timely manner. If we do it tomorrow, it won't. That's the problem. That is the problem. End of life. All right, so Jen, thank you for being here on 766.
Sure. So you have not made any changes at this point.
There was a recommendation.
Yes, you asked me to bring some
Yes.
language. Which I sent to you and the earlier this morning. I'm going to put that language up.
Kiki, do we have this bill or? Make sure we have still.
Do you want me to put up the amendment language, Madam Chair?
Please, what draft
Not-
is it for 766?
So we're still just looking at the as passed by House, except for this one
Okay,
potential piece of.
so Kiki will
language.
put it up today and then have it all together. Let's look at the proposed language from PMS.
Here it is. Some proposed language around, inhalers, so the idea here is that at least for purposes of looking at this language, we're amending the section that's actually already in the bill, but I'm treating it like. So at AVSA section 4089I, it's insurance coverage for prescription drugs. And this would be a potential new section requiring a health insurance or other health benefit plan offered by a health insurer or offered by a PBM on behalf of a health insurer, which is a lot of language in this existing section already, shall cover for beneficiaries under 18 years of age and without requiring prior authorization, at least one readily available asthma controller medication from each class of medication and mode of administration that is clinically, developmentally, and age appropriate for each age of beneficiary under 18 years of age. And as used in this subsection, readily available means the medication is not listed on a national drug shortage list, including lists maintained by the U.S. Food and Drug Administration and by the American Society of Health System Pharmacists. And then the rest is just moving the existing
So-
sections down.
We did hear testimony on this, but I'm gonna turn very brief, first ask Jen questions, any questions about the way it's written, and I'm gonna turn to, Jessa Barnard of VMS to give us the supporting information, why we're doing this, and I know we did hear testimony about it earlier, but it's a nice refresher. So we'll go right there, go ahead.
Sure. Do you want me to stay here? Does that work?
Yeah.
Okay. Jessa Barnard, Vermont Medical Society. You did hear testimony from pediatrician Kristen Connolly. This has been a big issue in pediatrics, really since the start of the new year. It's sort of two intersecting issues that have collided. One is which medications require prior authorization and which medications are available. So part of the problem is there is a national shortage of some of the most appropriate forms of inhaler controller medications. And so when the only other option has a prior authorization, it's forcing families and pediatricians to jump through a lot of hoops and have delays in access to these really life-saving medications. So the requirement of this language would be that one of the actual available medications that's not on a drug shortage would have to be available without prior authorization. And it was unclear to us, I'll just add, the reason it's new language, it hadn't, it sort of developed over the past, during the session, and also it is unclear to us, it's actually unlikely we think that H766 directly addresses this because medications are largely exempt from the prior authorization changes of the bill. So it needed to be specifically addressed with it.
That one in particular for kids.
For kids, for a medication that would otherwise be changed by 766 anyway.
I'm looking at Blue Cross. Yeah.
Sure. So Sarah Teachout at Blue Cross and Blue Shield of Vermont, we're very aware of this issue. The one medication that's currently not in shortage, we have no prior authorization up to age 6.
Okay. So it wouldn't be effective?
So 7 to 18 would be affected. I think 18 is pretty high from what I hear, that usually these are up to age 12. Is at least what the pediatricians ask for.
All right. We're not pediatricians.
I also think this doesn't apply to Medicaid, which I believe has prior auth for all ages.
Have to double check on the status of Medicaid. I think they did change their PAs.
But well,
This issue.
let's leave the language as it is, and it's got a ways to go anyway, so let's leave it right there. Okay, committee questions? All right, let's go through the bill as it is now. I know there were some places where suggestions had been made. But, so we'll go through the bill with an eye to, I think.
Apologies to those in the room who got to listen to me walk through this in finance committee yesterday.
They don't have possession of the bill, that's very unusual. We do that.
All right, so, H766, enacting prior authorizations, that therapy requirements, health insurance claims, and provider contracts. We'll go through and in a lot of detail unless you want to for any particular section. The first section is amending actually that same section of statute that we were just looking at, APSA 4089I, the health insurance coverage for prescription drugs. But a different piece of it, this is the step therapy part. And this makes some changes to the step therapy processes, particularly around people who are continuously enrolled in a plan offered by the same insurer, and so allowing them to bypass some step therapy and having exceptions granted to step therapy protocols upon request if someone is moving from one plan to another. To talk about when step therapy protocols are kind of appropriate and some exceptions for when it may not be based on certain characteristics either of the medication or the patient or both. Section 2 is the claims processing and claim edit standards language. This is the very kind of technical section about which edits edit standards, processes, and guidelines apply in which instances, and aligning the health insurance claims for outpatient and professional services and for facility claims with those in effect for Medicare. So aligning certain types of claims with Medicare, aligning the edits for pharmacy claims with appropriate nationally recognized edit standards, guidelines, or conventions, and then anything else would also be other appropriate nationally recognized edit standards, guidelines, or conventions approved by the commissioner. Some implementation provisions around recognizing that the Medicare edits may change over time and how those would be implemented by the payers. Adding to some existing exceptions to the requirement to adhere to certain edit standards. So under existing law, that's when necessary to comply with state or federal law for edits that are more favorable to providers than what would otherwise apply, or addressing new codes not yet incorporated by the payers' edit management software, as long as certain criteria are met. This adds new criteria that they are clearly supported by nationally recognized standards, guidelines, or conventions approved by the commissioner of financial regulation. We've got, again, some implementation provisions about how frequently payers can release edits, so not more than once quarterly, and how the new Medicare changes would apply and requiring notice to providers. Then we have the pre-payment coding validation edit review. Says that won't be allowed in most instances. This is where the payer requires the provider to provide medical record documentation along with or after submitting a claim, but before the claim has been adjudicated. And there's some exceptions stated in here for targeting review of a specific provider group, or facility under certain circumstances, some of which are specified. And then we have the some additional kind of updating language. And then the working group on page 9. This is reviving and modifying an existing or previous working group of the payers, providers, and DFR and other state agencies to look at trends in coding and billing that the payers are trying to address through claim editing, and only requiring a progress report to be submitted upon request. Later, you'll see this working group sunsets on January 1st, 2028. Section 3 is the first of two sections dealing with prior authorizations. Section 3 states legislative intent to reduce variability in prior authorization requirements by aligning to the greatest extent possible with the requirements in Vermont Medicaid. And it spells that out some, specifying that a health plan cannot impose prior authorization requirement that is more restrictive than the requirement that would apply for the same admission item, service, treatment, or procedure under Medicaid, requiring insurers to review Medicaid prior authorization requirements at least twice a year to make sure that they are maintaining proper alignment, and then some carve-outs saying that this prior authorization alignment with Medicaid does not apply to prescription drugs, does not apply to anything that is not covered by Vermont Medicaid that is covered by another payer. It does not prohibit prior authorization requirements for anything provided out of network, and it does not require plans to maintain the same provider network as Medicaid. And the rest of this is really some mainly cleanup, but also making it clear that the list of current list of services and supplies requiring prior authorization needs to be made available to the public on the insurer's website, so it can't be behind a subscriber login wall. Section 4 is the timing of responses to prior authorization requests. This is moving from 48 hours after receipt for urgent requests to 24 hours for urgent requests, and keeping the same 2 business days after receipt for non-urgent requests, adding in some additional requirements around notifying when to notify the provider or insured if more information is needed. And some more provisions around the implementation of the timing. There is provision in an existing law that does not change that says if the plan does not respond within the time limits set forth in here, then the request will be deemed granted. And then it specifies the duration of approval for of a prior authorization approval. So for a prescribed or ordered treatment, service, or course of medication, prior approval is in effect for the duration of that treatment, service, or medication, or 1 year, whichever is longer, except that for treatment, service, or course of medication that continues for more than 1 year, the plan cannot require renewal of the prior authorization more than once every 5 years. And also giving someone who is stable on a treatment, service, or medication as determined by a healthcare provider that was approved for coverage on a previous health plan, the plan cannot restrict coverage of that for at least 90 days when somebody joins and insures a new plan with the insurer. Section 5 is getting into the fair contract standards and the specifics of contracts between payers and providers. Some of it is just updating and housekeeping language, but there is a lot of language about what happens if a contracting entity uses policies or manuals to supplement the content of its contract with the provider. Must contain enough information to allow providers to understand and comply, and how rollouts of new policies or manuals or changes to existing policies or manuals would look like. So there's turning that language on that. Section 6 and 7 are the provider and insurer impact reports requiring by January 15th, 2027, each of the larger health insurers to report to this committee and others on the impact of the prior authorization provisions of this act on certain aspects within during plan years 2025 and 2026. So on utilization of services covered by the plans, development of the insurer's premium rates for future years, and the insurer's estimated avoided costs. And it talks a little bit about what goes into that, specific methodologies the insurer uses to determine them, the costs of alternatives that were ordered for insureds as a result of an insurer's denial of a request for prior authorization, and costs of emergency department visits and inpatient stays as a result of the insurer's denial of prior authorization pre-let. Section 7 is the provider impact report, and this is asking organizations that represent providers in the state who are affected by the prior authorization provisions in this act, asking them to gather information from their members twice before these provisions take effect and after 18 months regarding current circumstances and the impact of the prior authorization provisions of this act on the provider members and the members' practices, and requiring provider organizations to or asking them to report again by January 15th, 2027. So same date as the insurers on the impact of the prior authorization provisions of this act on their members' practices. Section 8 is the repeal of that claims edit working group. That's the sunset I mentioned that you would see later. And then finally we have effective dates. So the provider and insurer impact reports in this section take effect on passage. The prior authorization timeframes take effect on January 1st, 2025. SEPTA gives a carve out for an additional year for a plan that must modify its technology because it administers its own internal utilization review process for certain services that has an extra year for those services. And then everything else would take effect on January 1st, 2025, and apply to health plans, provider contracts, and claims processing on and after that date.
Questions for Jen? We've been through that. Okay. So, my suggestion is that we, look at both the proposed amendment and then we'll look at the bill and consider, voting on each of those.
Separately.
Yeah, that's how, yeah, first have to amend it. You're the clerk. We're gonna get down on the clerks. So the question on that was raised on the age of 18, I'd like to just have, that looked at by our medical society and our insurers, the age of 12 versus the age of 18. What does that do to the world?
Jessica Barnard, Vermont Medical Society, I had reached back out, see if I can get quick input on that. I know this was the request from the pulmonologists who were working on this issue. I think the issue is really the ability to actually use the mechanism of some of the medications available, because some of the powder forms require a deep inhalation that younger kids are not able to do. So certainly we would want it at, I know at a minimum of 12. What I think my read of the language is by saying age appropriate, that it could potentially be a different medication at different ages, not saying it has to be the same age in that for everybody up to same medication or mode of administration for everyone up to 18. I don't know if Blue Cross or Ledge Council agrees with that interpretation of how the language is written. But the
Age appropriate, it says under age of.
right, so it would have to be age appropriate within that band, but that doesn't necessarily mean that's the same mode of administration for that whole age range. It could be a different mode of administration up to age 12 versus 12 to 18.
Right, but we can't put that in there. We don't know what that is.
Correct. What I'm trying to say is I think the language is flexible enough to allow the payers to have different modes of administration up to age 18.
Let's turn to a payer.
Sorry, so I need to look at which ones we allow for different ages. You know, for example, I know that the one that's easiest to inhale, we already have no PA up to age 6. I thought that the request was to increase that to 12. So I don't know if we have a different one from 6 to 12 with no PA or above 12.
Well, it's age appropriate for each age of beneficiary, and then it says under 18. So would
Yeah.
that allow for discretion on the part of the payer?
I'm not sure, because I think we're following AMA guidelines on which type is appropriate for which age range. So let me look. I don't know if I can answer your question exactly.
You're gonna have to look
I will.
quick because we are about to vote this.
Okay.
And we usually vote the amendment first.
You are right.
I can pressure. So Jessica Barnard, again, I will say that age 12 is our highest priority if there needs to be adjustments. But I do think the language allows some flexibility, but the big issue is making sure that something's available.
I mean, if we just took out any age at all, that would go sky high, right? Goes up to whatever age you want. But, we need your professional input here. Both of you. We have 12 and we have 18. Let's take a little break. Okay. We're gonna take a 5-minute break and then we'll come right straight back to